contributions. Thank you. We have time, and I want to be clear with Bruce and Alan that it's 3 o'clock that we're targeting. It's correct. Great. So it's open for questions from the committee. I'll take the liberty as, again, the moderator to ask the first question. I'm trying to recall the history of this, but I recall that states began to require the M&M reviews of maternal mortalities as far back as the 1920s, 1930s. And Jackie, with your comment and presentation, would you be recommending to the CDC that they look at model or pilot programs where statewide M&Ms would integrate additional reviews of their cases or additional avenues for addressing other causes of maternal mortality?
In a word, yes. And it's fairly low-hanging fruit, as we say. You know, oh, that's a terrible metaphor, but anyway, that there is an opportunity there to just expand an ongoing endeavor just a little bit. And maybe to get those teams to be more interdisciplinary.
Great. Again, the same strategy is if you want to ask a question, please indicate by placing your name vertically, recognizing that we want to get as much input as possible. Gary Kleck, you're on.
Question for Matthew Miller. Are you aware of the evidence on gas detoxification and suicide in Scotland, the Netherlands, and Basel, Switzerland?
The places where you can see effects on overall suicide rates are places where the highly lethal method constitutes a large proportion of the overall suicide rates. And so I have looked at some of the data from the Netherlands. I have looked through the means restriction literature broadly. The studies in England and Wales by Kreitman and follow-up studies by Gunnell of the same time period but extended into different counties are the sort of they're the foundational and the state-of-the-art view of what happens when you restrict access to carbon monoxide in places where the rate of suicide due to that exposure is sufficiently high to see an effect on the overall.
It was high in Scotland too, and no effect there. No effect in any of those three places with a high or a low percentage carbon monoxide.
Well,
and also in England and Wales, somebody was kind of skeptical about Kreitman's results, and they followed up by looking at areas that hadn't yet detoxified within England and Wales because they didn't do it all at once. It was done in stages in different areas, and they found that the total suicide decline was actually slightly greater in the places that hadn't yet detoxified. Which means it wasn't the gas detoxification, it was just something else going on in England at that time. We don't know what it was, but it's not a pattern consistent with it being due to getting rid of one particular method of committing suicide.
I'm not sure that's right. I've reviewed this literature pretty extensively, and the Kreitman study and the follow-up by Gunnell show this huge change in method-specific suicide rates. Now, these are ecologic studies, right? And so to be able to see a large effect that's specific when you have some disconnect between the exposure as measured and what's happening on the ground in individual homes means that the relationship between the exposure and the outcome has to be particularly strong. You have to try to explain how rates of non-carbon monoxide suicide rates stayed the same. At the time you're explaining why suicide rates for the country as a whole went down profoundly in a way that's attributable to a decline in the method-specific rate. And the studies that are cited by people who do this research are Kreitman and Gunnell.
Right, but it's not the state of the art. The Barraclough studies that followed up, the ones I was referring to, those are the ones that disaggregated the data. You never favor national level data if you have smaller, more homogeneous, lower levels of aggregation. And it indicated it wasn't the places where they were where they were detoxifying gas where they observed those total declines in suicide. Yeah, they had declines in in domestic gas suicides. Of course, you can't kill yourself with non-toxic gas, but it didn't affect total suicide rates. So, you know, the Barraclough studies are the state of the art now. Were almost immediately after the Kreitman studies because they did things Kreitman didn't. It was clearly more advanced research. So, you know,
Well, that's an empirical question that the committee can go back and address.
Great. Did you want to comment, Julia, or did you have another question?
I have a question for Matt, but I can wait for him,
Oh.
of course.
Okay. Al?
There's a question for Dr. De Silva. You frequently brought the issue of mental health, mental illness to the table, and it's clear that there are lots of people with mental illness of many sorts. How specific can we be in identifying what kind of mental illness is relevant to be intervened with as individuals, and how specific can we be with the realization that false positive rates, if we're too broad, will be excessively unreasonable?
I think this is a very difficult question, that it is a struggle in the field in terms of, and that was one of the questions that we came up with in terms of, you know, how can we have some answer to that question? What kind of specific mental health issues can be related to what is specific kind of violence? That we do not have much of this answer. We have some data saying that, you know, depression is related to suicide. And then we have some ways of identifying depression and treating depression that is already, you know, pretty standard in the field. We also know that some other mental health issues like bipolar and schizophrenia can also be related to some kind of violence, you know, homicides and other things. But, you know, we do not have 100% sure of that. That's why we are suggesting that this be one of the areas of study.
But all of those are much more pervasive than the subset that are involved in homicides.
Yeah.
And especially in some of the mass shootings that much of the attention is. And until, it's not that we can't be 100%, but the percentage is very low that are identifiable. And that just strikes me as one of the major challenges in dealing with mental illness as any kind of indicator, because the relevant subset is just very small.
For some kind of violence, as you indicated, like mass shootings. But if we look at suicide, which is, you know, the largest incidence, there are some good indications about the relationship between depression and suicide. And that should be something that we would, you know,
But depression too is certainly pervasive, and only a small fraction of depressed people, I presume, end up committing suicide. And it's not just targeted here, but it's on all of the indicators that we've talked about are very broad and generic. And if there's going to be an intervention, it has to be more targeted, doesn't it?
Yes, definitely. Okay. I agree with that.
Great. David, and then Susan.
All right, this should be a quick answer one. Matthew, for the data on the suicide and then the mental health, how did you get the data for the mental health? What was that from?
So from the NISDA study.
Okay, very good. Oh, don't you love
You
them
might
when they
wanna-
have quick answer?
Well, you want to say what that NISDA, what does that mean?
It's
Some of
a
us are not
survey
familiar with that.
by the it's a survey. It's a very large survey that up until 2008 had only asked attempt questions of people with depression, but afterwards asked everyone in the survey whether they'd made attempts, whether they thought about suicide, and even prior to 2008 asked questions about substance abuse, about depressive disorder. And it's a large enough study that you can actually get representative rates at the state level.
Very good. And the second question was to Deborah Gordon-Smith. And at one point, you were talking about an intervention for a community being universal, but then also talking about it being targeted. And when I think about community interventions, you definitely need to shape them for the community. So if you could just clarify that for me, that'd be helpful.
Sure. So I was talking about really a comprehensive set of programs that included both the universal targeting the whole community around, with those various examples, but suggesting that from what we know now that probably would not be enough, and that embedded within that universal would need to be additional programs that targeted both at risk, but also those that were higher risk. So I don't know if that clarifies.
And if I could add, that's something that we've found for domestic violence prevention also, is that the broad-scale, universal, school-wide kinds of interventions are somewhat helpful, but there needs to be targeted ones to the youth at particular risk.
Susan?
I had a couple of questions, and one is maybe you just started to address it, Matt, but on one of your slides when you had that slide about suicide in the high and low gun states, you said cell counts were suppressed beginning in 2008. What do you mean by that?
Thank you. The data at small enough areas of aggregation were not available for some of the states with very few people and few suicides. Some of the states are so small that we couldn't actually get, for women and children, for example, cell counts. We couldn't get the data, even though it was presumably on the death certificate. So I guess one of the things that might speak to is is paying closer attention to whether really we're losing useful information by suppressing the information that researchers can have. Because of that, I wasn't able to go up through 2010.
Okay, good. I was wondering about it. And then a clarification for Jackie, too. We've heard a lot also, in addition to firearms, about strangulation. And I wanted to ask, because it's been raised before, and I wanted to hear it directly from you, is that when strangulation is taken into account, are guns still a much larger risk factor? And does the effect of strangulation sort of wash out when guns are taken into account? How does that work in your multivariate analysis?
Yeah, we did, although we find when we look at strangulation by itself, it does increase the risk, but yes, the gun ownership is far greater, which is interesting around that. But, it is a risk factor. It's good that we're starting to pay attention to it, but gun ownership is much stronger.
Okay. And then one last question. Thank you. Thank you. And this is for Deborah. You laid out 3 content areas. One is manage and cope with the context. This is for helping kids be more resilient, or for community level things. The second was social organization, or changing norms and attitudes. And the last was community and economic development stuff, which is an issue or an approach that usually is not seen as a public health approach, but involves more private sector as well as public sector. Among those 3, if you had to sort of put your money where your mouth is and help us choose as a committee where you think we should have some sort of research recommendations around those, to look at those, you know, because we were talking earlier about, you know, the business improvement
Right, districts,
districts, yeah, the BIDs and stuff. So
right.
where would you put it among those three if you had to choose
So,
one?
you know, so my answer probably will not be very satisfying. I guess you know, I think I'm going to say the obvious, right? I think we need to be doing all three of those things because the research in each of those areas is somewhat mixed, particularly in whether or not we can really make those kind of economic changes within communities. I think there are a number of examples where private sector has really dumped a lot of kind of economic resources, and that alone does not necessarily seem to be enough without attending to the social organization, the set of relationships within the neighborhood. And for me, there's always like, those things take longer to have an impact. So there's in the meanwhile, what do we do about helping people and kids and families who are living in those communities?
I guess I'm asking less from an intervention or policy point of view as to what areas of those three do you think is most in need of research right now?
I think both of I think we have more research on, we have evidence of effective programs in that first area so I think that's where we have the strongest evidence. I think the second two are where we have promising but not yet very strong evidence.
That's helpful. Lou? And then Jeff?
Julia, you raised the question directly, and Jacqueline raised it not as directly, but you said one of the things we need to know that we don't know is the effect of non-enforcement of legislation. Can you tell me some more about that?
Yeah, I have to come close. I'm a small woman. Yes, that we needed to know more to what extent the credibility and the perception that what is in the books is going to be enforced, and that I can, as a gun owner or a criminal or a person with intention of using guns, how that would affect my decision of using guns in terms of the perception that I won't be caught, and perception that, I can get away with what I'm doing, and that is, there will not be much consequences. So is that an issue that we'd like to see also if in some areas of gun violence, that is also a factor that, people may factor in terms of decision to use guns?
And I think that in the domestic violence gun removal arena, what is clear is it's as much implementation as enforcement. So in other words, if the protective order says you must list your guns here and then surrender each of them, or even getting from the partner the list of guns, that becomes very important, because otherwise many perpetrators will surrender one or two guns because the others they don't have papers on, or whatever, they don't think they count. And so it's some of those implementation strategies, getting the protective orders into the federal database right away as soon as it happens versus a week later. It's those kinds of things that where system doesn't help, is not enabled to do these implementation details very well. And enforcement matters too, but that's a big piece of it. And
does prosecution or prosecutorial decisions, is that, is that something that we would value in terms of looking downstream and in 3 years look back and say, I'm glad we asked that question?
And as our time is coming to a couple more minutes, several more minutes, but we want to keep these questions focused and helping to address that research agenda. So Jeff and Hendricks and John.
Sorry, this is not very focused. But I just wanted to reflect for a second. There's been a lot of allusions to the gains in road safety over the years, and yet a lot of the recommendations that have come forth have been very discrete. They've been behavioral, they've been technological, they have been judicial. I would submit to you that the gains in road safety have not been because of discrete efforts. They have been a comprehensive approach using public education and passage of laws and enforcement and judicial cooperation, as well as technology gains. And the study of our successes in road safety have been really around the interaction. Case in example, safety belts. If it's a good idea, 40% of people will comply. If you pass a law, you'll get another 15 or 20% of people who want to obey the law. They're law-abiding citizens. They're seatbelt bucklers. They're careful gun owners. If you enforce laws, you will get a compliance of around 80% with laws that are capable of being complied with, given that there is some surety of enforcement and prosecution. Then there is the 20%, and we all know about the 20%. And that difficult recalcitrant part of the population, I would submit, should be the target of much of our research. I haven't really heard about a comprehensive approach to that. So, I'm asking sort of for your reflections on research ideas about the interaction between possible, and even by the way our afternoon is constructed. It's one reason I want to ask the question now, Steve, is because we're going to separate off into these very discrete areas of research, when in fact I think there are some important questions to be asked around the interaction of gun users and the law and judges' willingness to enforce, and specialized courts for domestic violence and for repeat offenders and these sorts of things that I haven't heard a lot about. I think we'll have the chance, just like to get your reflection on that.
It's an excellent point, and especially when we're thinking about interventions. And I think this alludes to some of what was being said before. But like, for instance, if we do a universal education type thing or a universal kind of short intervention like preventing dating violence in schools, that we may need a totally different type of intervention for those, the tough ones, the highly traumatized kids. We may need a different sector. So it's not only in terms of, and there's tons of examples of interaction effects in all of these risks with guns. When you look at some of the domestic violence homicide records, you realize if the gun hadn't been there, accessible, loaded, not safely stored, that maybe there would have been a domestic violence incident, but nobody would have died. So there's that interaction of the gun being available. But there's several different strategies that would come in there in terms of the type of intervention you would do to prevent that homicide and go back and prevent the domestic violence in the first place. So it's a very good question, and one that you really need to look at on both sides.
I just want to essentially agree and say I think that part of what's hard is that we all recognize that there isn't a single answer here. And part of what I tried to lay out was the fact that we really need to be doing exactly what you're saying, talking about policy and the interaction between these other types of interventions. I think part of the problem in research is how do you evaluate the impact of that at a scale in a way that we can really do a rigorous evaluation of where the levers are and what the interaction is and those sorts of things. I think, CDC's approach actually has moved that way, at least in the area of youth violence. But I think the question is around, well, how do we rigorously evaluate whether or not that's really having the kind of intended impact that we expect?
Great. Hendricks, and then we'll finish with John.
I thought Jeff had a great question in here, but I'll try and stay with what our chair has said in here, be very specific about this one. And I had a question for Dr. Miller about the data that you presented about statewide comparisons. We know that there's huge variations in rates of suicide within states. And if you go down and look at the level of the rurality of communities, that those range, within a state by about a factor of 5 or so in many states, particularly out west. So do there exist data on reasonably good data at a smaller level, like at a county, on levels of gun ownership, for example, that could be used to replicate the analyses that you've been doing at the state level?
There are certainly mortality data at the county level, and in 2000.
I'm not talking about.
You want to know about gun ownership?
I'm talking about the independent variable that you were talking about.
Yeah.
Gun ownership.
Yeah. So in 2001, 2002, and 2004, the Behavioral Risk Factor Survey, which is a survey of over 200,000 people, was asked a question about gun ownership. And so for those years and those years only, we have information about gun ownership at the county level that's representative for some major at the county level. If you look at the correlation between the percentage of suicides due to guns and the measures of gun ownership at the county level or at the state level, what you find in cross-section is an astoundingly high correlation on the order of 0.9 correlation coefficient, 0.9, which is, it's almost a straight line. And so if you extrapolate from that and you look at the percentage of suicides due to guns in later years, you have a proxy in cross-section for the gun ownership that was determined only those years. But if we were to continue to do have the Behavioral Risk Factor Survey ask questions as they did, we would be able to continue to get those county measures. If you then organize the county measures into the degree of urbanization using a rural-urban continuum code, what you see is exactly what you said. You see much higher rates of suicide in rural compared to more urban areas. And when you disaggregate that into gun suicide versus non-gun suicide, what you see is rural areas have higher rates of firearm suicide. They do not have higher rates of non-firearm suicide. And rural areas also have higher rates of gun ownership. So the relationship that you see in ecologic studies, and that more importantly than any one particular ecologic study, that you see when you consider the totality of the data, including individual level studies, is that there's a very tight relationship between the presence of a gun in an area or in a home and the risk of death by suicide.
And one quick follow-up question about that. Is it worthwhile, or is it important, or do we know anything about new gun owners, the people who just buy a gun, compared to those who already have had a gun for 20 years in their home?
Well, it's something we really need to learn a lot more about why people acquire their first gun, why they get rid of their last gun. We really know very little about that. From a study that Dr. Kellerman did back in 92, we do know that very few completed suicides, at least in that study and in one or two others, very few completed suicides acquired their gun within the 2 weeks or month before the suicide. In Dr. Kellerman's study, it was only 3% of suicide decedents who died in their home in that study. In another study out of New Hampshire, it was about 8%.
Final word, John.
Great. And then very briefly for Dr. Gorman-Smith, just this issue we've heard a lot about changing social norms, and you've listed it as important. given that some of those social norms emerge out of the environmental context that people live in, do we know enough about what's most effective in terms rather changing social norms or making the environment safer, for example, and the same using the example that if you didn't change mental illness but change the lethality of means, you might actually have a big impact. Similarly here, do we know enough about which particular social norms one might target and then how they relate to the community context?
It's a good question. I think we know that we can change norms from previous research. If you just look at smoking and other kinds of behaviors, we know that we can have an impact. We have some preliminary data that suggests that, particularly looking in schools and communities where we work in Chicago, that people, kids and families, adults, tend to overestimate the extent to which people support aggression and violence as an outcome. And there's some preliminary evidence to suggest that when we feed that information back and let people know that it turns out that people think about this more similarly to you, that is one potential avenue for changing norms and attitudes. So we have some preliminary data to suggest that, as well as a lot of the family-focused work and building networks of support and changing social organization. But there's a lot more work to be done, obviously.
Great. Again, I want to thank the panelists for their comments, and this closes this afternoon's session. Alan?
So thanks, Steve, for an excellent job moderating 2 sessions. Well done, and thank you very much to the panel. It was extremely helpful. It now is the situation where we have enough input to write 17 reports, and the toughest thing is actually going to be honing this down into a priority research agenda. At this point, we will pause to have some public comment. We have 3 speakers who have registered to make comments, and I'll ask them to go to the microphone in a minute, and the clock will be running, and at the end of the 3 minutes that you're allocated, you're done. And then I would like to sort of charge the group for the next session. So don't go away after the public comments. I also want to mention that the slides will be posted on the public website, but that, of course, could take a little bit of time. So bear with us, but they will be made publicly available. Okay, so we have 3 speakers who have registered. Maybe let's start with Samia Altaf, who's the director of Cabson Consulting. Is Sabia here? Oh yeah, you don't have to sit up there anymore. Oh. Okay. So while we're looking for Samia Altaf, Sheldon Tepperman, who's a critical care surgeon at Jacobi Medical Center, please.
I thank the committee for this invitation. I'm going to be speaking fast because I only have 3 minutes. I'm Dr. Sheldon Tepperman. I'm a trauma surgeon and trauma medical director at the Level 1 Trauma Center at Jacobi Medical Center in the Bronx, New York. Jacobi is one of 6 of the Level 1 trauma centers of the Health and Hospitals Corporation of the City of New York. That's the largest public hospital system in the nation. I am also a 10-year board member of New Yorkers Against Gun Violence. I sit on the HHC Trauma Council and have been tasked by that council to chart a path forward for the city's trauma center-based injury prevention programs. Parenthetically, New York State has recently adopted the ACS Trauma Verification Program, and now all 40 of its trauma centers must adopt a more full-time approach to injury prevention. That's a requirement that this committee might explore or exploit there is also a very significant research requirement associated with the ACS verification program. New York State also maintains a database of all of its trauma centers, trauma registries, the risk-adjusted mortality. That database is ripe for the picking, and any of New York State's trauma centers have access to it. There is also the NTDB, which is the National Trauma Database, which is hosted by the American College of Surgeons and should be considered an asset in your work. There's very preliminary data that has just come out of that. I also want to second the comments about the tiered amendment and the suppression of data coming from trace data for ATF. That is a true impediment to your work. Back to New York City, we have two nascent trauma center-based youth violence reduction programs, one in Brooklyn, one in Harlem, and there is no published outcome data from these programs yet. Should we expand them in New York? Should I implement one of these programs in my heavy penetrating trauma center in New York City? Are these programs effective nationally? Staying with urban violence, we should focus on the semi-automatic handgun. This is a gun that is killing and maiming my kids. Dr. Winterman in JAMA 1996 wrote that the weapon has amongst the highest case fatality ratio of any known wounding vector or agent. There's a technology called microstamping on the books in California, not yet implemented. The gun lobby is more afraid of this technology than background checks and assault weapons combined. That should be very telling for the committee that it's likely to be wildly effective in reducing the devastation of these wounds. Microstamping research should be seriously looked at, and that's something for Mr. Ridgway's deterrent. The committee should look at the potential harm of the now stayed physician gag orders in Florida and now pending in 7 other states. We should also fund and promulgate more of the work that you've been hearing about Dr. Kellerman's work in the Journal of Trauma in 1992, which debunks the myth of self-defense. This kind of powerful, carefully worked out public health science is hard to argue with. Gunshot wounds to the spine and spinal cord injury are an underappreciated, devastating part of this equation that gets left out when we talk of the CDC's 31,000 gun deaths. I see far too many of these high cervical spine injuries, for example, that are ruining my kid's life, and yet PubMed hardly notices them. Finally, I'd like to recognize and applaud the work of Drs. Hemingway and Webster and Dr. Cook, who have bravely kept the lights on for us during a comparative period of research darkness. I use their work every day. And in conclusion, I pledge to advocate for New York City's enthusiastic participation in whatever your work product may yield. I thank you.
Thank you very much. And now let me call on Jim Piles, who's counsel of the American Psychoanalytic Association. Please.
Thanks very much, and thanks to the members of the committee. I'm Jim Piles. I represent the American Psychoanalytic Association, the oldest mental health practitioner association in the country. We're honored to be here to share our thoughts with you on firearm-related violence. We, like many others, were shocked and saddened by the shooting deaths of 26 people in Newtown, Connecticut on December the 14th, 2012. After a careful review of the facts of this and other mass shootings, we came to the conclusion that the most effective way to prevent such tragedies in the future is to intervene before mentally ill individuals are shooting the lock off an elementary school door. In short, we must do what we can to get guns out of the hands of mentally ill individuals who pose a threat to gun violence. The principal mechanism for preventing those who are a threat for violence from obtaining guns is the National Instant Criminal Background Check System, or NICS, mandated by the Brady Handgun Violence Prevention Act. However, the NICS system is both under-inclusive and over-inclusive and ineffective. 9 categories of people are to be reported to the NICS database. 1 category refers to those with mental illness, those who have been adjudicated as a mental defective or have been involuntarily committed to a mental institution. With the exception of the Virginia Tech shooter, none of the mass shooters in the past 15 years would have been reported to the NICS database. Conversely, the Brady Act requires the reporting of those with a mental illness to a criminal background database. Mental illness is not a crime. Further, it requires the reporting of the mentally ill even if they pose no threat for violence. The American Psychoanalytic believes that we can and we must do better. We must provide a process for identifying the mentally ill who are a threat for violence and reporting those individuals to a gun background check database, and the database should not be a criminal background database. We believe that there are reliable criteria for determining whether a mentally ill individual is a risk for gun violence, and there are criteria we'd be glad to supply to the committee. Accordingly, we recommend that the committee conduct research on ways to ensure that the mentally ill who are most likely to resort to gun violence are reported to the NICS database and validate the criteria for determining whether mentally ill individuals pose a threat for gun violence. We would welcome the opportunity to work with the committee, and I'd be glad to answer any questions committee members might have.
Thank you very much. We have a couple of minutes if there are, this is always risky. Don't do it. Yeah. Okay, I'm not going to do it. Let me talk a little bit about the next session of the workshop, because we really need to start the honing process. And the committee itself will, of course, when we go into executive session, will make sort of decisions about the realm of this. And so I warned some of you, dinner is not just a social event. We have a scheme. But the way these breakout groups are organized, there's about an hour for the panel to present, and then about an hour for the members of the committee to interact with the panel and try to distill from the discussions major research priorities that we would recommend. I think in earlier discussions we decided we can't recommend a research agenda that has 50 items on it. That wouldn't be terribly productive. We don't have a fixed number, but we do have to hone down to something that's manageable and will be useful to CDC. So you can have until 3:30 to get to your breakout rooms, but not 3:31. And then the committee as a whole will reconvene at 6:15 as marked on the agenda. No, 6:15 at the restaurant.
Just so everyone knows, on the back of your name badge, the guests who volunteered, or sorry, the guests who are here, is your assignment where we were able to stick you. We would ask that you please try to stay to your breakout due to space constraints. The breakout rooms are on the agenda, but I'll just quickly say them. The breakout A, which is characteristics, will remain here in room 100. Interventions, which is B, will go upstairs. You can just take the flight of stairs, or there's a bank of elevators right outside the door. You're in 204, so B is in 204. C, technology, is in 202. So 202 for technology. Video and media is 206. That's breakout D. So 206 for video. And risk is downstairs here. This is breakout E and 110. So thank you very much, and we look forward to convening in 15 minutes.
One more point. Let me repeat to the committee that we are not reconvening as a whole until 6:15. Okay? Please don't be late. We don't want to sleep there tonight.